Morning, everyone. My name is Brice Batomen. I am an assistant professor at the Dalla School of Public Health at the University of Toronto. And today we will talk about the hierarchy of evidence. Our outline, we will start about what do we care about causality. We talk about target population and target sample and study sample. We talk about what is an experiment. We will discuss a couple of study design, and we end up with the hierarchy of study design. So I am an epidemiologist, and epidemiology is the foundational science of public health. In public health, we want to improve the health at the population level. When you go to a physician, you want to improve your personal health. But in public health, the patient is the population. Because we want to improve the health at the population level, we need to intervene. Sometimes we want to implement policy. So we want to do stuff. We want to act on stuff in order to have change in health outcome. But for that, you need to act on causal factor. Because if you act on non-causal exposure, you will not change what you want to change. Or maybe you will end up having unexpected change, right? So let us consider this example of alcohol consumption and traffic collision. We know that alcohol consumption, today we know alcohol consumption increases the risk of traffic collision. This is a causal relationship. Coffee consumption, in contrast, do not increase the risk of traffic collision. This is a non-causal relationship. But suppose we didn't know that yet. And actually, when you run your study, you don't have the answer yet. If you already have the answer, why running the study? Now, suppose you run a study to know the relation between coffee and traffic collision. In your data, you may end up finding an association because people who drink alcohol also tend to drink coffee. Therefore, the observed association that we have between coffee and traffic collision is due to confounding. So coffee will appear to be linked to traffic collision because people who drink alcohol, which is the true risk factor, also tend to drink coffee. So the observed link between coffee and collision here is misleading. It's not coffee causing the risk, but alcohol. Coffee consumption might help to predict who is at risk, but it doesn't actually cause the risk. So if, for example, you are planning for emergency service, you want to plan the expected number of physicians, nurses, or beds that you need ready for next month to treat like trauma patient. Having a good idea about the number of coffee that have been sold in a shop can give you a good idea how to predict the number of injury that will arrive. But we are no way saying that drinking coffee causes collision. So targeting coffee consumption to reduce collision will be ineffective because it's based on a misunderstanding of causality. A central goal of epidemiology is to estimate causal effect, not just association. But epidemiology is not only about causality. We have several branches of epidemiology. One of them is it's called descriptive epidemiology. It's like taking a picture of the state of the health of your population. So here we want to describe pattern, prevalence, but we are not applying causation. And then you have predictive epidemiology, where we are using threat or tests to forecast disease risk or outcome. But again, you must distinguish with causal inference. Even if I'm just lay out these three branches of epidemiology, descriptive, predictive, and causal, in practice, the frontier between them are not always clear, right? But it's good to think about them as separate, because when you think about stuff like diagnostic testing, screening, it looks like predictive epidemiology, but there is a use causal aspect to it. But it's not the focus of this lecture, but you need to have that in mind. So we want to distinguish, for this lecture, we will be focusing on the causal epidemiology, which is concerned with causal effect. And to distinguish causation from mere association, many framework has been developed. But the one that I will use today is called counterfactual questioning. If you talk with philosophers and physicists, you will be surprised to learn that they don't agree what causation is. But for us in public health, using the counterfactual questioning has produced very good result. And I will explain what we mean by counterfactual questioning. So for example, let us consider that I received a text when I was driving. Then I pick up my phone to read it, and almost immediately I get into a crash. Did reading the text cause my crash? Asking whether reading the text caused my crash, so caused me being involved in a collision, means wondering what would have happened if I didn't read the text. If I would have trashed regardless, then reading the text did not cause the trash. If I wouldn't have trashed without reading the text, then it did cause the trash. So this kind of what if reasoning is a two experiment. So we are comparing actual event with hypothetical alternative. So let us consider an exposure, a treatment like reading the test that we call it A. A, we have two values in this example, in this scenario, in this hypothetical example that I use, because A will be 1 if I read the test, or 0 if I did not. So in our two experiment, I will have two potential outcomes. It's potential because we are not using any real data yet. We are still thinking about the question, right? Two potential outcomes. What would have happened if I read the test? So exposure 1, and what would be the outcome y1. Generally in mathematical textbook, we use the letter y for the outcome. Also, what would have happened if I didn't read the test? So exposure 0, and we denote the outcome y0. So the answer to the question I want to know is a causal effect, which will be comparing in our two experiment, the scenario where I received the test, I read it, to the scenario where I received the test and I didn't read it. But for me, at the same moment in time, it's for me at the same moment in time. Again, in the two experiment, there can be 4 results. It might be the case that in both scenarios, I will never be involved in a traffic or in a collision. We will say I'm human. Might be the case that in all the two scenarios, I will always be involved in a collision, then I was doomed. Might be the case that I will only be involved in the scenario where I didn't read the test, but not involved in the scenario where I did read the test. It's hard to think about it here, but if my exposure was something preventive like vaccine, and the outcome was something like an infectious diseases, then this scenario is more likely. Or it might be in a scenario where I will be involved when reading the test, but not involved if I did not pick my phone to read the test. But we don't know in which scenario I am, because we can only observe one. Because we want to know the causal effect constructing the two scenarios for me at the same moment in time. But there's no way we can have that information. But you need to think about that. You need to consider that two experiment in order to come down to the real world and try to mimic that to answer the question. So as I was saying, counterfactual scenario, where we can only observe one of the scenario. So to match the real world with our two experiment, we need to make assumption. The first of those is temporality. The cause must occur before it effect. Right? I need to receive the test, pick my phone to read it and see what will happen. I cannot wait for the collision to happen and then pick my phone to read it. If I measure picking the phone and reading the test after the collision, maybe I was picking my phone to test someone that I was just involved in a collision. So the cause must precede the effect. Consistency. Here we must assume that the outcome that I experience when reading the test is the same as in the scenario in our took experiment when I did read the test. Likewise, similarly, we need to assume that the outcome, if I did not read the test, is the same as in the scenario in the took experiment when I didn't read the test. Look how I framed the question. Please receive a test by driving, pick up his phone to read it. If I have defined the exposition as Brice was reading the test, is that a really precise definition of the exposition? Maybe I have a fancy car where when I receive the test, the car can read the test to me. Or I have fancy earphone where I could, the phone or the smartwatch can read the test to me. So the level of distraction will be different. So when even when thinking about the scenario in the dog experiment, in the scenario of reading the test, if I'm not as precise as picking the phone to read the test, so in the scenario of reading the test, there can be many different versions of reading the test, and those versions can lead to different results. So you need to be as precise as possible when you consider the exposition, or also when you consider the control condition. The control condition is not picking my phone to read the test. If I were just defining the control condition as not reading the test, if I'm not reading the test but I'm sleepy, yes, I'm not reading the test, but in the scenario of not reading the test, if I'm not as precise, maybe I'm sleeping, maybe I'm impaired because I just have a couple of drinks coming off from a party, maybe I'm tired. There are many other scenarios into not reading the test. So I need to be as precise as possible for the two scenarios to be very well defined in order to allow for the comparison. And I also need to have data where people were exposed in the way that I define it. So if in the data I have, there's no way to know if the person actually picked the phone to read the test, or if he heard the test to his headphone, I cannot answer the question. But again, in reality, I either read the test or I did not. So even if the intervention is well defined as in my question, picking the phone to read the test, in reality, either I picked my phone, I read, or I did not. So in reality, we can only observe one of the scenario in the real world. We cannot observe both. So even if temporality is ensured, and even if the consistency is ensured, I can only observe one of the two scenarios. That's why we say causal inference is with causal inference, you only have a missing data. The missing data is that you can only observe one of the two things you need. Now that we have a missing data, to resolve that issue, we move from an individual. So we move from Brice to a group of people. So a group of people that receive a test, but among them, some read it, pick the phone to read, and others did not. Okay. Now that we move from individual to people, we cannot construct the average of the income. So in the scenario where a group of people pick their phone to read the test, we count the number of collisions, we take the average. That's what we mean by expectation. And in the scenario where a group of people did not read the test, we count the number of collisions, we take the average, and we make the subtraction between the two. And the difference will be the average causal effect. Average because now we move from an individual to a population. But there's no free lunch. Because we move from individual to a population, we need to, it's a brilliant idea, but it came with additional assumption. And one of the additional assumptions is that the group of people need to be similar. That's what we call exchangeability. So the exposed and unexposed are similar in all relevant ways. If the exposed individual have not been exposed, they will have shown the same outcome as the unexposed group. Likewise, if the unexposed individual has been exposed, they will have shown the same outcome as the exposed group. In randomized experiment, because we control the assignment of the intervention, so you are the one, you toss a coin and people receive the treatment or not. Because people need to actually give the treatment to people. Sometimes you have a protocol where you clearly define what is the treatment. You clearly define what is the control, placebo or not. You clearly define the dosage. And because you do these two stuff, generally the temporality and the consistency might be ensured. Note that those temporality and consistency and many of the assumptions we discussed today are not stuff that you can prove in a mathematical formula. It's a matter of debate. So is your question well defined? Depend of your ability to convince people that are knowledgeable of the field that your intervention is really well defined. So if you're in a room with public health research and road safety, and you have a question for an exposure in road safety, if when you define your exposition, people in the room have a similar way to think about it, then you might say your intervention is well defined. Because if they had a Duke experiment where they think about the scenario, in the scenario of being exposed, if they think about it in the same way, then your exposition will be well defined. But there's not a mathematical formula to prove it, it's a matter of discussion. So as I say, because we move from individual to group, we need to make sure the group are comparable. So randomization helps for that, but in expectation. Because if you have randomization, is like tossing a coin. If you have a fair coin and you toss it 10 times, you will be unlikely to have 5 head, 5 tail. You may end up with 7 head, 3 tail. So that's why in randomized trial, we do sample size calculation to know how many people we need to make sure that the exchangeability might hold in expectation to kind of see the difference. And this is an analogy. It's not exactly that, but I'm kind of using an analogy. So in observational study, we need to adjust for variable, right? For example, in an early example of alcohol, where we're trying to look at linking coffee to collision. If my study is like, is drinking coffee is related to collision, because I'm not randomizing people to drink coffee or not, I need to adjust to measure a lot of factors that I think might confound the association. So we measure on alcohol. I may also measure like sex, age, many other factors. Because I have a lot of this factor, I cannot do the computation by hand. Sometimes I will use regression. Again, there's no free lunch. If I use regression, that will arrive with additional assumption, including positivity. Even if I don't use regression, even if I'm doing the computation by hand, because I have to adjust to make the group comparable, I need to consider positivity because every individual in the study should have a positive probability of receiving any version of the treatment. So if, for example, for the coffee and alcohol drinking example, if in the group of people not drinking coffee, there's no one drinking alcohol, I need to adjust for alcohol, for example. If in the group of people not drinking alcohol, there is no one drinking coffee there, it means that among the non-alcoholic, non-alcohol drinker, not alcoholic, non-alcohol drinker, I cannot contract the coffee drinker and the non-coffee drinker because in the group of people not drinking alcohol, everyone also don't drink coffee. So there's a violation, positivity violation there. So to answer question of the sort, what is the average causal effect of an exposure on the outcome? We need to satisfy some assumption. Consistency, well-defined treatment. Another example that we use a lot to explain consistency is when people say, suppose you're a physician, you receive a patient for like cardiovascular issue, and you ask the patient to lose 3 kilograms in the next month. Is that a well-defined intervention? That patient can go home, start exercise regularly, start eating more vegetable, going in bed in regular time. After 1 month, 3 kilograms he has lost. The same patient can go back home, start smoking heavily for the next month, and maybe after 3 months, the patient will also lose 3 kilograms. So that corresponds to the same scenario of losing 3 kilograms. I'm pretty sure if you're in a room with people working in that field and you say your exposition is losing 3 kilograms, everyone will hear like you, like, what do you mean by losing 3 kilograms? This is what we mean by having a well-defined intervention. Exchangeability, even with consistency, we only can observe one of the potential outcomes. So that's why we move from individual to group. So the group need to be comparable. Positivity, sometimes you need to adjust for a lot of factors to make the group comparable. So you have to make sure that by adjusting by those factors, when you look within strata of those factors, everyone can be exposed or not. The other factor that I did not talk a lot about, like interference. So my treatment is not impacting other people's outcome. So in the testing traffic collision example, yes, I test and then I hit someone. That person wasn't testing or maybe wasn't testing. We don't know. But my exposure impact another person outcome because it was involved in a collision. So maybe the best way to define the outcome here for this type of study is like being responsible in a collision to kind of deal with the interference issue. There are also measurement error because you need to measure the exposition. Are you exposed or not? You need to measure the outcome. Are you involved in a collision or not? Are you need to measure, for example, the age of the participant, the sex, whether impaired when driving, all those factors. If you don't measure those factors well, you will have measurement error and then bias. Even if I use a binary example of reading the test way versus not reading, the counterfactual questioning also work for continuous exposure. So far, we were talking about the condition, the assumption we need to answer a causal question, but we haven't talked about on which population do we intend to estimate the causal effect. In real life, when you run a study, yes, sometimes you want to know what happened to the study participant, but you want to use that information to apply to a population, right? You don't only care to what happened to people in the past. You want to use that to help for the future. So the right way to frame the question is what is the average causal effect of an intervention on a given outcome in a particular setting? So the target population refers to the group of individuals relevant to our scientific inquiry. So it's the population for which we aim to estimate the causal effect of an exposure. So when you read many studies, generally it's not explicitly mentioned in the paper. And you might think that the target population were people in the study. No, people in the study were the study sample. So you should always start with your target population. To which population I want to apply the result of this question. And then you sample from that target population people that will be in your study. And if the people you sample, the way you sample people, you're ensuring that it's representative, then it's jackpot. So a causal effect is not fully specified without defining a target population. So internal validity refers to the validity of the causal effect within a study sample. And for that, we need to certify the assumption that are listed above: temporality, consistency, changeability, positivity, and a new one, which is no selection bias. So, for example, I want to do a study about driver in Douala, Cameroon. The study sample a sample driver from Douala, but in some I wasn't able to ask to measure the exposition if they read the test when they receive one. For some, I was unable to measure if they were involved in a collision. For some, I was unable to measure the age or their sex. So I will exclude those. So maybe I sample 1,000. Now I'm running my analysis in 400 participants because for the other I did not have the information. So I have a selection by a year because those that end up from which I'm running the analysis to have the result are different from the initial group from which I sample from the target population. Now, if suppose that my question is well defined, I'm pretty certain about temporality, measure all the factors that will make the group comparable, measure everything correctly, no measurement error. I make sure that I'm not removing people from a study sample because I'm missing information. Then my result will be internally valid. Now, I want to know that for the driver of Douala, this is my target population, right? So because my sample was taken from driver to Douala, so I can do what we call generalizability. So I could use the result I used in my study sample and move that back to the driver in Douala or the driver in Douala because I sample from that population. If my sample was well done and they are representative, it will be easy to do that generalization. But if I want to use that result for driver in Kampala, it will be more challenging because the study sample is not coming from my target sample. Then we call that type of exercise transportability. You have to make, again, there's no free lunch. You have to make some assumption. It's not the focus of the lecture, but I want to explain exactly how you should think about internal and external validity too. So the key, the causal effect is not fully defined without the target population. So now we talk about the assumption for causal effect, and we also say you need to start with the target population first. And then now we start talking about some design. The well-known and experiment. By experiment, we mean that you have control into which get the exposition or not, the intervention or not. And we have randomized trial. Why are they so popular? They are popular because they have good reputation, because remember, we move from individual to group because we can only observe one of the scenarios. We move to individual to group. So when we move to group, we need to make them comparable. But do we really know all the factors we need to adjust for to make the group comparable? Because sometimes we are ignorant because we don't know a lot, because we are learning, every day we are learning more. Maybe in 10 years with new discovery in physics, in biology, there are some factors that we were not considered as confounder for a relation between coffee and alcohol, or between between coffee and traffic collision, or between testing and being involved in a collision. That today will be that in 10 years we need to adjust for confounding. So because we cannot know all those factors, we have statisticians in the middle of the 20th century proposed the idea of randomization, randomizing who will receive the intervention or not. And 20 years since after that, we have Bradford Hill that performed the first modern clinical trial to look at the treatment of streptomycin for tuberculosis. And since then, randomized trials have been very popular in public health and medicine. So if you want to represent that through a graph, you have a treatment and outcome. Many factors could make the treatment group to be different to the control group. So here an example like health seeking. But because I'm the one assigning those who receive the treatment or not, if the randomization has been well done, I have enough sample size, then even the health seeking behavior will be similar between the treated and not treated. So this is why this is the strength of randomized experiment. However, in randomization, we have very hard criteria, very high level, hard criteria to include people in the study. So one the example that we use is like, if you have a pregnant woman that have an issue, for example, headache, and all the randomized trial for drug that we use to treat headache have been done among non-pregnant people, right? Because why? The criteria to be involved in the study will be rare randomized trial to include pregnant women sometimes. So the target population to which you want to use some result, the study sample is not part of that target population. And also, sometimes in public health, not all interventions are random, can be randomized due to ethical reasons, cost, resource, time constraint. So understanding this issue is important. So we know the issue of internal validity. They can also give us a light in terms of external validity. So for example, if in the study I one driver in Dalla, I don't have all the people in my study sample, while in the target population of the driver of Dalla, I have all the people, I need to think about that when trying to move what I learn in my study sample to the target population. So in trial, as I just explained, the study sample in a trial might be very different to the target population. So that's why always thinking about randomized trial as the gold standard is more nuanced. And we talk about that in 5 slides. So maybe the gold standard is a double randomized trial, where you first randomly sample the study sample from the target population, and then in the study sample, you randomize the treatment. Then when you are not randomizing the treatment, so when you don't have the control into which will be into people that will receive, you are not the one responsible for giving the treatment or not to people. So people end up to be exposed and not exposed. and you still want to study them, you are not in the territory of observational study. Within observational study, you have a ton of this type of design. So there we only focus on 3 of them. You have cohort study, where you track different people with different exposure level, and you measure the occurrence of the outcome, the frequency of the outcome among them. But you are not the one assigning the treatment. So these studies are often seen as less reliable for establishing causality due to threat of internal validity, because you're not the one assigning the treatment, which you are concerned about. Maybe the group are not comparable. But they might offer strong external validity because the criteria to include people is not as high in clinical trial. So you might be closer. The result can be easily generalizable. I have some issue pronouncing that word, but you can transfer the result from the study sample to the target population. So, but you should always keep your assumption in mind, right? Temporality, consistency, exchangeability, positivity, selection bias, and measurement error. So if you want to represent that with a graph, you have smoking, death, and you need to adjust for age, right? But in this case, you're not the one randomizing people to smoke or not. It's not even possible because it's not ethical. So if you adjust for age, you will be removing part of the confounding to make the group comparable. Case control study are also a type of observational study, and in the next couple of lectures, you will have more detail about case control study. But the difference with cohort study is that while with cohort study, we follow participants over time based on their exposure status. With case control study, we start by identifying people with the outcome, and we call them case, and those without, and we call them control. So in traffic safety, for example, the case will be driver involved in road traffic collision. Typically in practice, it will be people you're using data from hospitalization or emergency visit. And then to get the exposure status, you maybe will be blood alcohol and for concentration, presence of alcohol in blood tests, or self-reported drinking, which might be problematic because people may lie. And to get the control, if someone was involved in a traffic collision Sunday 8 p.m., you will go in the same road the next Sunday 8 p.m. and you will randomly stop driver and then you will perform the alcohol test on them. This might be a way to go. The key is that the driver who were not involved in collision should represent the driving population from which the case arose. Again, we will talk more about the criteria or how to perform a case control study in the next couple of lectures. So in case control study, we look backward to assess the exposure among those who had the outcome versus those who did not, within a defined time frame. Case control study can be more complex to interpret due to challenge in establishing the temporal relationship because we are looking backward. And also there are many ways to select the control, and depending on that, the interpretation might change too. Again, it's the same assumption that you need to think about. So if you want to represent a case control, you will have the exposure, the outcome, but because you start with the cases, so it's a kind of a sampling among those who have the outcome. But case control studies are efficient. When we say efficient, it's because imagine a study like smoking and lung cancer. If you want to do a trial or a cohort study, it would take decades in order to be able to establish, to measure to have an answer because the relationship, because the exposure and the outcome take a long time. So why with the case control study, you start by the hand with people who already have the cancer that you're studying and you look backward for the exposure. But you need to define the time frame where you are looking back. Also, sometimes if to measure the exposition is very costly, like if the blood alcohol concentration is very costly or require a lot of resources, taking blood sample, transferring for test, something like that, maybe you don't have enough fund to do that for all the study participants. But by sampling, by only taking case and sampling control, you reduce the number of people for which you need to do that. So you should always think about a case control study as being implicitly nested within the control study. Again, we will cover in the next couple of lectures on case control study. Again, how control are selected determine how you will interpret the result. There are many variations of case control study. One of them is case crossover. They actually were suited for our examples of receiving a test, testing, and being involved in a traffic collision. They actually, I think there have been studies that have been done using the case crossover design. So the key here is that they are very suitable for short-term exposure. So when you think that the effect of an exposure vanish quickly, like with the testing, we think it's because you are distracted that you will be involved in a traffic collision. So after you read, you go back to unaware why we should be distracted in the next 10 minutes, for example. Maybe you read a bad news and then you are not in the right state of mind. But this is the type of, before thinking about a case crossover, you should have an idea of how you think the exposure is related to your outcome. And what we do, we are comparing period when an individual is exposed. You might say the next 15 minutes after I read the test versus the next 15 minutes when someone is not exposed. You can divide the time as you want, but I'm just giving you an idea. So you compare period when an individual was exposed with period when they were not. But the difference with our Took experiment here is that it's different period. What in our Took experiment when we wanted to compare what would have happened if I received the test and read it versus at the same moment I received the test and didn't read it. Here we will be comparing maybe 30 minutes when I received a test and I read it, within 30 minutes when I received the test but I didn't read it. So highly effective for accurate outcome, trial like traffic collision. And there are many other variations of case control strategy that they use in traffic safety. So if you are more interested, you can check this paper by Kim and Mooney in the International Journal of Epidemiology. It is open access, so you can access it. Finally, we talk about quasi-experimental study. Quasi means we try to be as close as possible to an experiment study. We still doesn't have control into which we get the treatment or not, but we find a variation in the way the treatment happened in the real life. And we think that that variation is only related to the outcome through the exposure. So one of the famous examples was the one performed in the middle of the 19th century in London by John Snow, where he used that variation of that we make people exposed, meaning drinking contaminated water. That variation is through which company you are receiving your water. And the outcome was cholera. If you want to do a cohort study or a case control study, you need to adjust for factor like income to make the group comparable. While when you use that variation of which company is giving the water, you're assuming that the only way that variation could impact cholera outcome, which is getting cholera, is through the water is giving to people. But if, for example, you reassure how you will receive the water from some company, maybe income will also impact the company, so then you have to adjust for that. But I'm just giving you the general framework. And cross-experimental studies are becoming more and more popular because they allow for a retrospective evaluation of trial, or retrospective evaluation of policy when the trial is no longer possible. And they also allow for evaluation of system change that are hard to manipulate experimentally. So we talk about what is causality, what is the assumption we need, the importance of target population. We talk about randomized trial, a couple type of observational study design. The title of this lecture was Hierarchy of Study Design. And if you do a quick Google search about hierarchy of study design, we always find picture like this, which is like pyramid, where we rank study, and in the top of the pyramid, meaning the best level of evidence, you will find meta-analysis or systematic review of randomized trial. So like everything, have good and bad element on it. The issue that I have with those type of pyramid classification is that it's not a personal issue, it's like the community of epidemiologists. is that this hierarchy is often doesn't clarify what is the type of question that we are using to decide which one is best. You might say this is pyramid is only for causal questions. So when you want to answer a question of what is the causal effect of A on Y in a particular setting, meta-analysis of randomized trial is the best type of evidence. Another step is like, okay, but which criteria are you using to state that? Probably internal validity, as we saw, randomization allowed that the group are comparable, temporality, consistency, no measurement error. Measurement error can also happen in randomization too. But at least because randomization ensures these three stuff generally, that's maybe why we are saying meta-analysis of randomized trial is the best. But in reality, stuff are more nuanced because different study design are suited to different questions. So case report might be good if you want to identify rare disease presentation, where a randomized trial will be impractical or unethical. And even if you have a very like causal comparison that you want to make, there are situations where observational study will be actually better suited. Because the benefit of randomization depend on conducting on an intention to treat analysis, meaning that you compare people that have been randomized to be exposed to people that have been randomized to be non-exposed. But in real life, we have the adherence issue. You randomize people to be treated, but not all of them take the treatment. Or you randomize people to be in the control group, but some of them manage to receive the treatment. And when you start performing analysis as per protocol or as treated, meaning you compare people who actually receive the treatment versus people who actually didn't receive the treatment, you lose all the benefit of randomization is lost. So it becomes, the randomized trial becomes an observational study. Another issue is that randomized trials are expensive. There are a lot of constraints to perform a trial. And because of that, sometimes we end up with small trial. Remember my example, if you toss a coin 10 times, you might end up having 7 tail and 3 head. So can we really talk about exchangeability? Some people say that doesn't create bias, it's mostly creating precision, meaning that you have a result with very large, wide confidence interval. But even in terms of bias, we may have a lot of confounding there because the group are not comparable. We don't have enough sample size. And also in trial, intervention and treatment are delivered in a more rigorous way compared to real life. So yes, we are very meticulous, but in a real life, people will not receive the treatment as in the trial. So there might be a mismatch when you want to transfer to make the generalization from the study sample in the trial to the target population. And randomization is not always feasible, especially when we're talking of public health or policy context. So because of all of that, we need to think a little bit beyond internal validity only. I'm hardcore into internal validity. You should do your best to think about the assumption we talk about and make sure that they are satisfied to the best of your ability. But you should also consider your target population. So I'm not here to say whatever observational study you would pick there is comparable to randomized trial. No, this is not what I'm saying. But you need to consider all those issues when assessing the quality of the evidence that you have in front of you. So external validity and population level impact may produce evidence that inform the public health policy more effectively. Because you just want to know what happened to people that were in the study. You want to use that to change the population, the health of your population. So people are pushing toward pragmatic randomized trial, where you perform a trial in a less selected population. And you use an intervention in a way that you define the intervention in the way that closely mirror how it could be implemented in practice. And also a lot of people are using quasi-experimental design. But this training focuses on case control study. And through the next lecture, we will show you what you should take into account to make sure that temporality hold, your question is well defined. What is your target population? Are the group comparable? The human error, selection bias, positivity issue. So thank you very much. Here is my contact. If you have any question, feel free to reach out to me. Here are the list of references from which I borrow to make the slide. I highly recommend to check this book. I borrow a lot from this book, from chapter 3, 6, 7, 8, and 9. Thank you so much and have a good evening.